Thanks. So good evening, everyone. We all know that we are doing these national webinars regularly. And now with this new team, this is our first webinar. And we have Vaibhav and Ajita who are helping us in coordinating these national webinar sessions. So the previous team has done a very good work. And we have got the feedback forms also from them. And many of you have given a lot of suggestions regarding the new topics, and we are looking into it. Hepatoblastoma and liver tumors were one of those topics, and we have arranged the national webinar on that. We have Dr. Yadav also, who's the chairperson of PHO. I would like to invite Dr. Yadav to speak few words.
Satya, you're muted.
Yeah. Hi, good evening, everyone. So I welcome you to today's webinar and I congratulate the new EB for organizing a very good topic, liver tumors, which is very, very important, something not seen very regularly in our practice. But when it comes, you need to know everything and you need to manage it the right way. So let's hope we learn from today's webinar. All the very best to everyone. Thank you.
Thank you, sir. So with this, as we all know, that liver tumors is a teamwork. Actually, we need a multidisciplinary team to make a good care, to take a good care of these patients. So I would like to invite Dr. Girish. We all know Dr. Girish is head of the department in Tata Memorial Hospital, and I think he's one of the best person to talk about this topic and make us learn about it. So thank you, Dr. Girish, for joining today and giving your time for this national webinar, and welcome.
Absolutely. Thanks, Shweta and Satya, and again, congratulations for the new EB who have taken over and starting the webinar series. Are you able to see my slide and hear me well?
Yes.
Yes, Girish.
Yes.
So if the slides don't move, please let me know. So what I will do the next 20 minutes or so is talk about, give an overview about risk stratification based treatment for hepatoblastoma and what are the evolution of strategies which have come up for actually improving the outcomes. So as Dr. Satyada already said, it's a very rare tumor. Less than 5% of our practice is actually hepatoblastomas or malignant liver tumors, what we see. However, because it's a rare tumor, risk-adapted multimodal therapy has actually transformed outcomes through various cooperative groups. And for the standard risk disease, you today have excellent outcome of more than 80% long-term survival. Nevertheless, high-risk disease and metastatic disease continue to be a challenge. And surgical techniques, especially orthotopic liver transplantation, has actually made a huge impact in managing these high-risk diseases. But what we must all remember is that even though the outcome in the first time may be very good, a hepatoblastoma which relapses has an extremely poor outcome and is generally not salvageable in our country. So it is critical for us to actually get it right the first time, and we actually have to all work together, even though it may be a rare tumor, to actually get the best outcome for the child. Now, there are many liver tumors which occur in children, varying from benign vascular malformations which occur in infancy, the hemangiomas, infantile hemangiomas, etc., to benign tumors, some of them which require only surgery, like adenomas and mesenchymal hematomas, and tumors like focal nodular hyperplasia, which does not require any therapy at all and can be observed. However, as pediatric oncology teams, we commonly encounter these malignant tumors, which is hepatoblasma, which occurs in the very young child, hepatocellular carcinoma, which tends to occur in adolescents in more than 10 years of age, and rarely we do get undifferentiated embryonal sarcomas of the liver, which is a small proportion of malignant liver tumors we see. Of late, there is, especially in the last decade, we have now identified a tumor called hepatocellular neoplasm, NOS, which overlaps a hepatoblastoma and hepatocellular carcinoma, and we will discuss that as we come to the end of the presentation. So there are two crucial factors which are necessary for us to understand hepatoblastoma better. And these two factors, insight into this, has actually helped us to treat hepatoblastoma much better than what we did many decades ago. One is alpha fetoprotein. So it's not just about knowing it as a tumor marker, We need to understand the response of alpha fetoprotein, or what we call the alpha fetoprotein kinetics, on treatment to understand whether the hepatoblastoma is going to do well, or we'll be able to cure the child with the hepatoblastoma or not. The second crucial component is actually an imaging, and having an excellent imaging upfront as well as on treatment is very crucial for to plan the surgical treatment. And as you will know by the end of this webinar, that surgery, hepatoblastoma is a surgical tumor, and that plays the most important aspect of management. So appropriate imaging is crucial, and what is required is what is called a triphasic scan. The triphasic scan includes a hepatic arterial phase, a portal venous phase, and a delayed phase. And all this is required for you to delineate the vascular architecture of the liver, which is crucial in the surgical management, as you will see in the subsequent slides. You could also do a contrast enhanced MRI, which is done in many, many centers. And it is critical to look at the lungs, do a metastatic workup upfront, which is the common site where metastasis occurs in about 20 to 25% of the hepatoblastomas we see. Now, a lot of credit has to be given to this gentleman called Claude Couineau, who is a French surgeon and anatomist who actually understood the vascular architecture of the liver and was able to anatomically delineate the various liver segments based on the supply of the blood to those segments. And this was crucial for actually planning the surgery. And this he did in the 1950s. And based on his description in the 1950s, the liver is divided into 4 sections. There are 8 segments of the liver. Segment 1 is the caudate, which is not shown in the diagram here because it's posterior. And segment 2 and 3 are what are called the left lateral sections. Segment 4 is the left medial section. The segment 5 and 8 are the right anterior section, and the segment 7 and 6 are the right posterior section. And as you can see, each of them have got their independent blood supply. So if you're going to have a tumor in that particular segment, you can remove the whole segment with the blood supply, and that is how the surgery is actually planned. Now, based on the description by Quino, you now have what is called the pre-treatment extent of disease, which was described well in the 70s. Now, there are 4 sections, as I already showed. If 3 sections of the liver are free, then you call it what is called pretext 1. The image on the left with a tumor below from a CT scan is what you can see. So here, you would just do a right posterior segmentectomy or hepatectomy, and the rest 3 sections would be clear. Pretext 2 is when 2 sections of the liver is involved, and here you will have to do a left or a right hepatectomy, or sometimes even a central hepatectomy, depending on what kind of, where the tumor is actually located. Pretext 3 is when only one section of the liver is free, and 3 sections have got disease in them. What I have shown in pretext 3 and 4 are multifocal disease, but you need not have multifocal disease. You could just have a single mass occupying 3 sections of the liver and only one section being free. And in pretext 4, all 4 sections of the liver are involved. And when you look at it upfront, it seems unlikely that surgery would be possible. There are additional factors which surgeons will need to take into account before planning the treatment, and hence a dialogue with the surgeon and the radiologist is extremely critical. You look at how the veins have been involved, portal and hepatic veins, whether tumor is single tumor or multifocal tumor, because multifocal tumors may have microscopic foci which radiology is not picking up, and hence the recurrence could be higher. You could have disease outside the liver, extrahepatic disease, which needs to be taken into account. Sometimes tumor rupture upfront, and that actually can have seedling in the peritoneum, and hence you might need to treat with chemotherapy aggressively, involvement of the caudate loop, and lastly but not the least is metastasis, which makes it a high-risk disease. And all this has an impact on surgical resectability, relapse risk, and long-term survival. So does histology really matter? And I'm sure many of you know that having a tumor marker elevated with a radiological diagnosis of what is suspected to be a hepatoblastoma is generally sufficient in the, say, 6 months to 3 years, or 1 to 4 years, or 1 to 5 years of age for us to tell that we are dealing with a hepatoblastoma, and biopsy is not usually required. However, in the very young, AFP is significantly elevated physiologically, and it becomes difficult for us to tell whether it's a physiological elevation or actually it's from the tumor, and hence a biopsy may be required. So the histology are generally classified into epithelial type or mixed epithelial type, but that is not critically important for us to take a clinical decision. But the next 3 points are what is critical for us to take a clinical decision. If we get a pure, well-differentiated fetal epithelial type in an upfront resected tumor, then that is a very good risk disease, and many times chemotherapy is not required. If you find a small cell undifferentiated tumor, it was usually generally considered a high risk disease, but of late that has been found to be not so bad at all. And then the third component, which I said, it's a hepatocellular neoplasm NOS, or which has an overlapping features of hepatocellular carcinoma and hepatoblastoma, which tends to do not as good as hepatoblastoma, and we will discuss that later. Conventionally, especially in India, most people followed the SAIPL protocol, and tumors were divided into two: standard risk and high risk disease. Anything which was pretext 1, 2, 3, that means one section was free for surgery, did not have any of the annotations, or AFP was more than 100, and there was no metastasis, was considered standard risk, and all others were considered as high risk disease. And the outcome with 6 cycles of cisplatin for standard risk, or doxorubicin and cisplatin or carboplatin based treatment, actually gave an outcome of 90% for the standard risk and about 60 to 70% long term survival for the high risk disease. However, everybody was not following the SAIPL risk stratification. And this is data from India itself, which is using the same SAIPL risk stratification and treatment strategies. And as you can see, the standard risk outcome was more than 90%, and high risk has about 70%. And similar data was also replicated from Chennai as well. However, everybody were not using the same risk stratification, and there was variation in risk stratification between various cooperative groups, which made comparison of data very difficult, and which made even more difficult to actually launch a multinational international trial. So these were the 4 major groups treating hepatoblastoma, and some of them had a category called a very low risk disease. Some of them had a category called intermediate risk disease, and all this made it a bit complicated. And some of the factors used, like tumor rupture, was not used in some, using alpha fetoprotein less than 100 was not used in the others, focality was not used by all of them, and all this made it a very heterogeneous group, and this needed to be harmonized. And for that, the Children's Hepatic International Collaboration was formed, called the CHIC, or the CHIC Global Collaboration, and 8 trials conducted by these 4 groups were actually harmonized into one database, and there were actually 1,605 hepatoblastoma. So we must remember this is a very, very rare disease, and hence it was critical to actually pool all the data together. And these 4 groups had 1,600 hepatoblastoma, which is the largest database of hepatoblastoma ever you will get. And once they pooled it all, they identified 5 backbones based on the pretext extension of the disease, based on the metastatic nature of the disease, and if alpha fetoprotein was less than 100. What they did on this was they did multiple univariate on multivariate analysis on each of the backbone, and used a hierarchical pattern on a tree and identified various other new risk factors which may actually predict outcome. So this identified additional risk factors, and the additional risk factors which were not so far identified included age. Children more than 7 years of age or 8 years plus did much worse than children younger than that. And that could be because of the changing pathology which I mentioned, of the hepatocellular neoplasm not otherwise specified, which had features of both hepatoblastoma and hepatocellular carcinoma, and hence actually did not do very well. Alpha fetoprotein levels at baseline, if they were very high, more than 1 million, actually had a suboptimal outcome, although the data on the number of patients on that was small for that to be included as a risk factor, but very low level, less than 100, continued to do worse. The low AFP actually predicted poor outcome. In the previous trials, biopsy was not done in all of them. And if you had a liver tumor with low AFP less than 100, they were treated as high-risk disease. But when actually central review of the pathology was done for all the small cell undifferentiated and AFP less than 100, they actually found that about 20% of the cases were actually rhabdoid tumors. We must understand that rhabdoid tumor was actually discovered only in the 1990s. And all these trials, many of these trials have data before the 1990s. And their rhabdoid tumor was not identified, and the SMARC-B1 loss on immunohistochemistry did not exist. So if you remove the rhabdoid tumors from the liver tumors who had AFP less than 100, and you only had a small cell undifferentiated and hepatoblastoma with AFP less than 100, they did not do that badly at all. So AFP less than 100, which is not a rhabdoid tumor, had an overall survival of about 60%, and the small cell undifferentiated about 70%. Nevertheless, AFP less than 100 had a suboptimal outcome compared to those who had a much higher AFP. Focality of the disease, as we discussed, means that the tumor is arising at multiple areas of the liver. Even though you may find foci on radiology, the suspicion is that there are microscopic foci of disease which are not picked up by radiology, and hence you may underdo the surgery component in this, and hence the outcome on this continue to be poor as well. And so this continued to be picked up as a risk factor across all groups. So bringing all these factors together, the new factors which are highlighted in red were actually included in the new risk stratification. All others existed even before. Was focality, multifocality was high-risk disease, AFP less than 100 was high-risk disease, age more than 8 years was high-risk disease. And based on that, the new risk stratification based on pretext 1, 2, 3, and 4 would add a very low risk, intermediate, and high risk. I will not go through in detail, and all of you can look up this on the papers, but essentially metastatic disease more than 8 years did not do that well at all. Based on this new risk stratification, a global trial was designed, and it was called the Pediatric Hepatic International Tumor Trial that included both hepatoblastomas and hepatocellular carcinomas. The ones which are highlighted in color are all the hepatoblastoma arms. There were 4 questions asked, group A, B, C, and D. Again, all of you can look this up, but I will tell you what were the important study questions which were asked. For the very low risk, which had a well-differentiated fetal histology and upfront surgery, no chemotherapy was required, and that they wanted to continue to study and check whether the high survival was maintained. However, if you did an upfront surgery and you found it was not a well-differentiated fetal histology, but pretext 1 and 2, then 2 cycles cisplatin was enough to get an excellent outcome. For low-risk disease, which was resectable early after 2 cycles, the duration of cisplatin was decreased from 6 to 4, and they wanted to test by a non-inferiority trial whether 4 gave the as good an outcome as 6 cycles, which was traditional, and hence a non-inferiority trial was planned. For those which are not unresectable after 2 cycles, continue to get 6 cycles of cisplatin. For the intermediate risk, because various groups had different combinations of treatment, a 3-way randomization was done between the 3 arms, 3 chemotherapy protocols which are listed in the table there. And the idea was to compare the outcome and toxicity with the hope that you would potentially reduce doxorubicin dependency and decrease doxorubicin toxicity in the intermediate risk group. And for the high risk group, what SIAPL-4 had shown, that after neoadjuvant chemotherapy, the metastatic disease disappeared, then the outcome was excellent. But if the metastasis did not go, then the outcome was not good. So they actually devised 2 arms in the high-risk disease. Those who had metastatic clearance went on to just get standard SIAPL-4 protocol. Those where metastasis did not clear, they tried new drugs with etoposide, vincristine, and irinotecan, and this was a randomized trial. So trial is completed in 2025, more than 1,000 patients recruited, and the follow-up will end in 2026. And we expect numerous papers to come out in the next 2 to 3 years, and which will also, this trial will also validate the risk stratification of CHIC. And we hope that if that comes out successful, it will give a new pathway on how we actually treat hepatoblastoma across the world. For those of you who want to know what is the intermediate time, what we should do, from the FIT consortium, they've actually made a global consensus paper telling what should be the interim chemotherapy guidelines. This is published in 2025. You can look up this paper. It's an excellent paper which actually tells you how to treat hepatoblastoma, HCC, HCN, NOS, and hepatocellular carcinoma based on the learnings which are happened consensus during the FIT trial. For the next few slides, I would like to talk about the surgical component, which is an extremely important component of hepatoblastoma management, because we must all remember that hepatoblastoma is undoubtedly a surgical tumor. Without a good surgery, there is no question of curing a hepatoblastoma. So upfront resection should be done only in select cases. Pretext 1 and 2, child less than 8 years of age and AFP more than 100. And the surgeon and the radiologist should be able to assess that there's a 1 centimeter margin from the vessels, then you can go and do the surgery. You must assess for surgery early if you are not doing an upfront resection. If you are every 2 cycles, you must do an imaging and see whether the child is fit for surgery. and avoid delaying the surgery for more than 4 cycles. There's no great benefit of giving 7 and 8 cycles versus 3 and 4 cycles for the surgical component. And always operate when surgeon feels tumor is resectable, not on a fixed time point after every cycle. If the surgeon feels that at 2 cycles it's operable, we go and operate at 2 cycles. We don't wait because the original protocol said to do it after 6 cycles. Additional cycles of chemotherapy are unlikely to benefit surgical resection, and refer early to an experienced surgeon or liver transplant unit if you think that surgery is going to get complicated. So giving more than 2 to 4 cycles does not really benefit surgery, and there is evidence for that. Drug resistance, which is the MDR1 gene expression, upfront, if there are only about 25%, after neoadjuvant chemotherapy increases 4 times to about 100%. So which clearly means that as you continue to give chemotherapy, the MDR gene expression increases and chemo resistance increases. And at relapse, it is much, much more as well. And if you did a combination analysis, which have been done by some of the groups before, using an AFP and a tumor volume combination kinetics, you will find that after second or third cycle, you actually reach a plateau, and hence giving more chemotherapy cycle will not make it much easier to operate. So please go in and operate as soon as you can, or refer early if you cannot operate it. So liver transplant indications are very clear. If you have a pretext for multifocal disease, or a pretext for unifocal, which continues to be post-text 4 after neoadjuvant chemotherapy, or a pretext 3 with major vascular involvement, needs to be referred early, right in the beginning for a liver transplant. However, there are people who have recently or in the last decade published that there is no need to transplant all of them, but I would deal with that with a lot of caution. So extreme liver resection should be planned in difficult cases where normally you would have referred to a transplant by a high volume center where there are very good experienced liver surgeons to actually deal with it. Multifocal disease, if the foci disappear, there have been some papers where they say that you can leave that section of liver behind. But remember that radiology has got limited reliability to tell you that the tumor has gone. However, if there is exceptional chemo response, both in terms of AFP and radiology, you could consider, but again, I would say that is more the exception than actually the rule. We must all remember is to involve the liver transplant team at diagnosis, because this requires a lot of planning. And you need to also do the liver transplant like a surgery at 4 or 6 cycles, and not leave it till the end of treatment when the tumor is more resistant. And you must remember that metastatic disease or extrahepatic disease must reach remission with your chemotherapy before you plan transplant. Surgical margins matter. This is for the trainees. So even if you after surgery you find microscopic surgery, margins are positive, it does not impact the outcome, and you did not go in and do surgery again. However, if you have a macroscopic disease left behind, or macroscopic margins positive, then the outcome is poor and re-resection has to be planned for. Remember that spontaneous rupture of hepatoblastoma, which is reported in 2 to 10% in literature, is not uncommon in India, occurs in the first week when they come to the hospital. Hence, start treatment ASAP, preferably on day 1 or day 2, because that decreases the vascularity of the tumor and the chances of rupture become much less. Understanding AFP kinetics is crucial. As you can see in this case, between day 0 to day 90, the AFP started coming down. But if you see between day 90 to day 120, actually plateaued. So surgery was done at that time and then it crashed, which means that if the AFP starts plateauing, please go in early with surgery and remove the tumor, because what you have is resistant hepatoblastoma there. And does rate of AFP decline to therapy actually matter? There are studies, one of which was done by Shyam Srinivasan from Tata Hospital itself. He looked at about 100 plus hepatoblastomas and saw that if you had a more than log reduction, 1 log reduction after 2 cycles, more than 90% reduction in AFP, the survival was much better than those where you did not have more than 1 log reduction. And there is a meta-analysis too, which was published in 2021, which shows that the rate of AFP decline actually correlates with outcome, and a good AFP decline correlates with a more optimal outcome. And normalization of AFP pre-surgery also has a better outcome. However, never delay the surgery to make the AFP normal, because what you have is actually a resistant tumor, and you must take the tumor out early. What about AFP levels for OLT? This is one of the common questions which we discuss. Before doing a transplant, should the AFP is high? Is it a good case to transplant or no? We do not have as much data as in hepatocellular carcinoma, but poor AFP decline has a poor outcome. And our general feeling is that in a pre-OLT, if the AFP is very high, then the outcome may not be good. And this is the case even in non-metastatic disease as well. The last bit, the next two slides, is what I will discuss about this new entity which was described in 2000 in about 10 years back by the Children's Oncology Group. First, Dr. Ranganathan, who is a pathologist of the COG, was one of the pioneers in understanding this. But there is something called hepatocellular neoplasm (NOS). Now, as you can see in the diagram on the left, you have hepatoblastoma, which occurs in the very young age group, hepatocellular carcinoma, which occurs much later, and in between, you have hepatoblastoma with carcinoma-like features, which are called the transitional tumors or intermediary tumors. And the graph on the right shows that the HCN NOS does not do as well as a hepatoblastoma. And this summarizes what we actually see. On the left column, hepatoblastoma, you can see occurs in the very young children. Pediatric hepatocellular carcinoma occurs in the older children. And in between 5 to 10 or 5 to 9 years is where these tumors commonly occur. They're reported as hepatoblastoma. When we actually look at the genomics, they have TERT promoter mutations. They do have TP53 alterations. All these which make them an unstable genome and give a lot of drug resistance to the chemotherapy what we use. These are more stem cell disease. AFP decline is poor, and the tumor response is suboptimal, and they behave more like HCC. In these situations, it's better to plan early surgery or transplant rather than give the full chemotherapy as was originally planned. So I think I will stop here with this one slide. What I would like to say about hepatoblastoma optimizing outcomes is a constant real-time dialogue for every child from the beginning of treatment between the surgeon, radiologist, and the pediatric oncologist. We must understand the AFP and the radiological response and plan treatment, surgery especially as possible. And timing is extremely crucial. So I will stop here, and then we can discuss more in the panel discussion.
Thank you, sir, for that wonderful insights and comprehensive summary of the treatment of hepatoblastoma and highlighting the FIT trials, as well as highlighting the importance of early surgery whenever possible and just not wait for AFP decline. There are a few questions in the chat box we can take to before the panel discussion, both by Dr. Raj Warrior. Comments on genetic factors, Beckwith-Weidman with parental uniparental disomy, and the possibility of increased recurrence there, and whether you have seen any angiosarcoma of the liver children.
Yes, sir. So Beckwith-Weidman syndrome, so when we get it with hepatoblastoma, we have to screen them right from beginning, even when they don't have the tumor. And we serially follow them up both with alpha-fetoprotein as well as ultrasound, not only for the liver tumors, for other tumors as well. But what I do not know is there's an increased risk of recurrence because the 2-3 tumors what we have treated have seemed to have all done well, but I'm not sure if there's an increased risk of recurrence, but there's increased risk of metachronous tumors or other tumors coming in those conditions. Regarding angiosarcoma of the liver, yes, we have seen, in fact, some of them, what we thought was benign hemangiomas or hemangioendotheliomas in the liver, which have not been biopsied, some of them on treatment with propranolol, etc., rapidly increased in size. And when we actually biopsied 1.5 years later, were angiosarcomas, and then a treatment of combination using vinblastine, bevacizumab, and propranolol, etc., had an extremely poor outcome, and we actually did not manage to salvage them at all.
Girish, can you hear me?
Yeah, yes, sir. Yes, sir.
I just have two comments. I don't want to disturb your talk, but I have two comments. One is the parental disomy is very interesting. If it's a father who gets the tumor, the mother don't get the tumor.
Yes.
So you can check the UPD. If his father, risk of recurrence is high, risk of tumor is also high. And angiosarcoma, we just had a patient we were able to describe a new gene just published in developmental pathology. It's a particular MAF gene that's associated with endothelial sinus development. So angiosarcoma of the liver, we have just discovered new gene that's abnormal in some of the angiosarcoma patients, just for information. So I think every patient that you see now, you should probably do genetic studies for you to get, you have such a large volume. I think every patient should have genomic sequencing done just to be looking for anomalies.
Thank you, sir.
Thank you.
Thank you. Points well taken, sir. Any comments by Dr. Girish on that? Exome in all patients?
Sorry?
So nothing, sir. Just your comments on exome in, like when do we do genetics?
Yeah, no, we are not doing genetics on any one of them at all at the moment. So we are not really doing that on a routine thing. But what sir is saying is absolutely right, because what comes from the paternal one is what affects more, and so that probably has a higher risk of recurrence as well.
Okay, sir. Thank you, sir. So there are a few more questions,
Thank
but
you.
for want of time, I think we'll proceed with the panel discussion. And if it is possible, can you answer in the chat box only, sir? And maybe if you're available, we can take the rest of the questions at the end of the session if time permits. So thanks a lot. Maybe a few questions will be answered by the panel discussion. And now we can move on to the next session, panel discussion by Dr. Dharani Jayaraman, who is a consultant PHO and BMT physician at Rela Institute of Medical Sciences. So the panelists will be Dr. Julia Scott, who is the head and senior consultant PHO at Rela Institute, Dr. Gomati Narasimhan, who is the liver transplant physician as well as hepatobiliary surgeon at Rela Institute, and Dr. Divakar Sharma, who is the consultant histopath and molecular pathology at HN Reliance Hospital, Mumbai, and Dr. Satish Kumar, who's the consultant intervention radiologist at Apollo Chennai. Over to Dr. Dharani.
Thank you, Ajita. If I may request you to share the slides, please, first. I sincerely thank the opportunity by the IAPPHO team for us to present this panel discussion on multidisciplinary approach in the hepatocellular neoplasms. Thanks, Ajita, for introducing the panelists. Next slide. So we have 5 panelists here. So we will directly go to the session. Hepatoblastoma. Next slide, please. So the hepatoblastoma has been well known as a common tumor under the age of 2 years, associated with very low birth weight, extreme prematurity, pretext, AFP, histopathology, all that Dr. Girish has highlighted very well. And the treatment includes chemotherapy and surgery or liver transplant in certain situations, and has a very good prognosis. The next slide, please. So these are the common clinical presentations: subdomen distension, liver mass, thrombocytosis, the syndromes associated. We have to be careful while monitoring. There have been some familial cases reported where we have to look for FAP, and rare presentations. We have had one child who had a precocious puberty. The next, please. So who had a precocious puberty when he presented with 21 months of age with hepatoblastoma. And the beta HCG is the implicating factor here. The next slide. So we know the history of hepatoblastoma. It has been there since 1887. The initial tumor treatment has always been surgical treatment, which has evolved over time. And the chemotherapeutic options has been introduced. And however, we have been successful with the chemotherapy only since 1980s. Where the cisplatin becomes the backbone of therapy. COG, Cyopel, German group, Japanese group, so all collaborative groups have worked extensively on hepatoblastoma. And finally, we have come together and have this Children's Hepatic Tumor International Collaboration, which Dr. Girish has highlighted, and the FIT trial, which is giving us the answers that we want right now, and we are expecting more. The next slide. So with this, I'll start with the case-based discussion. So this was our first patient who managed in our institute, who was a 9-year-old boy. Evaluation for abdominal pain, he was noted to have a mass in the right lobe of the liver. The baseline investigations were normal. Serum AFP was elevated at 3,308. The next slide. So this was the CT abdomen, which showed a mass in the segment 6 of the liver involving the right lobe, and it was pretext 1. HRCT chest showed no evidence of metastasis. I would like to open the question to our pediatric oncologist, Dr. Julia Scott first. How will you approach this case, sir? How do we go about it?
Okay, so as Grish clearly told, this age 8 years with the liver mass, with the elevated AFP, although it is not that very high. So we should not consider hepatoblastoma here. We would consider hepatocellular carcinoma or the tumor he mentioned, that is the tumor which occurs in older children with hybrid features, previously was called as transitional liver tumor, and the recent pathology entity is HCN invoice, that is hepatocellular neoplasm, not otherwise specified. So definitely a biopsy is indicated here or a surgical resection.
Thank you, sir. Next slide, Ajita. So this, before going into the biopsy, this child had a biopsy elsewhere and came to us. Before going into that, I would like to ask Dr. Satish, what all we should be knowing when we plan an image-guided biopsy.
Okay, so image-guided biopsy per se, we would always like to go through a normal cuff of liver. So first and foremost, a screening ultrasound to see whether that is feasible or not. In this particular case, I think it's a pretext one, maybe have an MDT to discuss we need a biopsy at all, just go for a resection straight away. But answering your question, the main thing we look for is vascularity and whether we can go through a cuff of liver. So those are the two main things. And of course, nowadays we tend to take about 5 or 6 cores. Previously, it used to be just 2 cores. Now with all the molecular testing that are required, we need to take at least 6 cores of tissue. So of course, and first to 24 hours, we try not to mobilize them in a slightly older age group, not always possible in a child, purely because the clot that forms on the layer of the capsule of the liver, if it dislodges, then there could be delayed bleeding. So the first to 24 hours, even though the first 6 hours is crucial, the first to 24 hours is very, very high risk for bleeding.
Thank you, sir. So this was the International Pathology Symposium classification and guidelines. Sir has highlighted all this. Of course, FNAC is definitely not a choice anyway. And biopsy of adjoining normal liver should be taken for molecular test is the other recommendation that has come up. So passing through healthy liver, sir has already highlighted. So the next slide. As mentioned, this child had a biopsy elsewhere, and we got to review the biopsy tissue in our institute, which showed a tumor with cells polygonal and arranged in sheets and trabecules, demonstrating high NC ratio and typical malignant cells. The next slide. Next slide. So the IHC was done with hepar glypican being positive and glutamine synthetase locally positive. The next slide. So with this histology and IHC, the initial impression of pathological impression was that beta-catenin mutated, well-differentiated hepatocellular carcinoma grade 1. So this was our pathological diagnosis. I would like to ask Dr. Girish and Dr. Scott again, how do we go about with this management?
Yeah, this we would go for surgery only. Girish.
Yeah, I agree. I think if it's operable, we would just operate and not do anything else.
Thank you, sir. Next slide, Ajita, please. So I would like to request Gomati ma'am to comment on the surgical aspect. So this child had a robotic right hepatectomy. Ma'am, could you please take upon the surgical aspects? What are the principles that we should be knowing? And what is the concept of future liver remnant when we consider a resection or extreme resection?
Sure. Thank you very much. I think the initial talk by Dr. Girish was very well covered on all aspects. Actually, he spoke very beautifully about the surgical aspects also. The principles of surgery essentially revolve around each of these behaving like a block, each segment. So you can essentially think about removing one of those without really damaging the rest. Now here in this particular child, we saw that the lesion was restricted to 6, although in the report it mentioned another lesion in segment 7 also. So we are looking at 6 and 7, which is the right posterior segment. And 2-segment resection is essentially something which is where we would not really worry about the functional liver remnant at all. But as a concept, what we need to understand is when we are planning liver resections, number one is how much liver do we have to remove to provide good margin. And anatomical resections, I saw a question in the chat box asking about non-anatomical versus anatomical resection. And now wherever preferable, anatomical resections would be better for many reasons. One most important reason though is the likelihood of bile leaks post-op is much lesser when it is anatomical resection. And these are children who post-surgery, you need a quick recovery if you have to give them chemotherapy and stuff, not particularly this child, but any of these hepatoblastomas. So you want them to have a quick recovery. And so anatomical resections give you that extra margin of safety when it comes to that. So that is one aspect. And second thing would be if we were planning a major resection, that's when this question of functional liver remnant comes into play. So functional liver remnant is when you're planning on doing more than 4 segments, that is right hepatectomy, extended right hepatectomy, or extended left. So what you're left with will become the remnant liver, and the functional component of that is calculated by how much is the total liver and what is that proportion that you're going to leave behind. So a safe margin will be somewhere about 25% at least of the liver that is left behind. Of course, exceptional studies have been that saying you can go up to 16%, 20%, but I would say looking at a 25% is a safe margin when you're planning a resection on these children. The other important component is minimally invasive surgery that's come up now, and laparoscopic, especially when it comes to when these children have normal liver. Remnant liver is quite normal in most of them. Cirrhotic is not the condition in children. So robotic hepatectomy or laparoscopic hepatectomy gives them the advantage of quick recovery to move on to the next stage of treatment.
Thank you, ma'am. Thank you for those insights. Next slide, please, Ajita. So this child, as mentioned, had underwent a robotic right hepatectomy, and these were the pathology slides from the resected specimen. Next slide, please. Yeah, next slide. Yeah, I request the pathologist to comment on this. The final diagnosis of the resected tumor tissue was suggestive of a well-differentiated epithelial hepatoblastoma, fetal epithelial type. So I would like to ask you, how do we explain this discrepancy, sir, diagnostic versus post-surgical excision? Dr. Divakar.
Hi, everyone. So this case actually perfectly illustrates the unusual but recognized conundrum that we all pathologists have been facing for a decade or more so. And there is a significant overlap, like how Dr. Girish mentioned, between well-differentiated hepatoblastomas and well-differentiated hepatocellular carcinoma, especially in children who are more than 5 years old or specifically around 8 years of age. And just to reiterate what Dr. Girish said in his talk and Dr. Scott also mentioned, this situation was actually published almost 25 years ago. And these tumors were known as transitional liver cell tumors, in which the pathologists were not able to, either by morphology or by IHC, or because of the overlap between the two, which we all now known as hepatocellular neoplasm, NOS. But just before I discuss on this specific case, I just want to ask Dr. Girish or someone else that how many diagnoses of NOS are you guys seeing nowadays, especially after the 2025 PHIT consensus article that was published in 2025?
Dr. Divakar, I must say that we are not seeing as much as we expected. But said that, I think it is a pathological difficult. It's very difficult in pathology to classify it as that, without probably looking for third promoter mutations and P53 and other things, for example, because a lot of them have an AFP which is in 5-10,000 and many times as reported as hepatoblastoma. But if you look at the response, they are not as good as a routine hepatoblastoma, especially the AFP doesn't drop that well at all. So from that point of view, I think we are underdiagnosing them probably. And some of them have been reported, but I have a feeling that we are underdiagnosing them rather than truly assuming that we are seeing less of it.
So completely agree with you, sir. But with this particular case, we can imagine on a limited core biopsy, we don't even know whether, like how Dr. Sorry, I missed her name. So Dr. Dareni.
Dareni, yeah.
Darini. She mentioned that multiple multifocal areas should be taken for taking biopsies so that different biological spectrums, if there are that exist in a tumor, the intertumoral heterogeneity which there is in a liver tumor can be represented on a biopsy, which a tiny biopsy that a pathologist get. In this case, possibly they saw pure hepatocellular morphology and a 9-year-old child, so they probably favored HCC. Again, IHC is not a good basic definition of NOS versus hepatoblastoma. HCC specifically, these scenarios, we already had report as a beta catenin HCC, which HCCs are extremely rarely seen. Doctors to have over features and called it a HCC. And this category of HC and NOS has been reported, like, for example, initially on biopsy, it was called HCC or hepatoblastoma, and on resection, a completely vice versa diagnosis was noted. Even mixed scenarios where mixture of both the morphologies, as in opposing each other's, were also reported. So I wouldn't basically say anything about that, but it was possible that in this case they could have reported it as HC and NOS if there were some overlapping features which they saw. But like in the PHITT consensus, these HC and NOS tumors are supposedly to be treated like a high-risk hepatoblastoma, only like HCCs. I don't know how much impact this has on actual clinical management or not.
Thank you, sir. So you rightly mentioned about the risk stratification along with the histological typing. So we know the common histological subtypes of hepatoblastoma, and the pathological classification has been revised, and like the treatment protocols are being evolved, our pathological classifications are also getting evolved. And we've already discussed the HC and NOS in detail. The next slide, please. So this has again been discussed by Dr. Girish. I'm not going into the detail. Like it was discussed, the molecular does help in situations, especially like this, the TERT mutation and the beta-catenin mutations and TP53 does help in further classification. Next slide. So with this background, I would like to ask Dr. Girish and Dr. Scott, how do we treat this child further? With what role of adjuvant with a recent risk stratification? Next slide.
So basically, this child, we had a lot of confusion whether to like how to approach because of the age and also about the initial pathological confusions. Although the AFP normalized, we had some expert opinion from Dr. Madhumita from Sayopal. And finally, we gave an adjuvant of 4 cycles. So Girish, what you would have done, age more than 8 years and multifocal initially, but completely resected, well differentiated.
No, this was not multifocal. No, was it multifocal?
Radiologically,
It was.
Yes,
Okay.
it was.
yeah,
It was.
Yeah. So if it is multifocal disease, age more than 8 years, then probably would definitely give chemotherapy.
Yeah. So that's what we did, and we are following up. He's doing well. And we did
Next
an
slide,
NGS.
Ajit.
We did an NGS for this child because of this confusion, but that came as, nothing significant.
Can you go to the next slide, Ajita? Next slide. So the risk stratification protocols has been already discussed. So with this pretext one and this classification, we have clearly discussed the various risk factors, the age, AFP, pretext, all being on the higher side. We did treat the child with chemotherapy. Yeah.
Yeah, the
So
one more
after,
point, Dharani, you need to highlight is the residents should understand that the AFP of less than 100 is clearly bad prognosis. But there are some articles coming up, studies showing more than 10 lakhs has a prognostic value. It is like bad prognostic value. And another thing is 100 to 1000 has a prognostic value. So there was a study which clearly shows that more than 1000 AFP and comparison with 100 to 1000 has a significantly different outcome. So this protocol, actually this risk stratification divides that AFP into 100 to 1000 also. And Girish has already pointed out this less than 1 log reduction of AFP is very, very significant actually. We can actually talk to the parents if the first AFP decline, it's not very good. Because many times we will see the AFP, it is 8 lakhs or something, and we look at the second one. If it is like comparable with the previous one, it is 7 lakhs, anyhow 1 lakh less, it is not enough actually. The 8 lakhs usually should become 80,000, and the 80,000 should become 8,000. Unless and until the decline is like that, the response will not be very good.
thank you, sir. I think you have already answered me the next question. Ajita, next slide, please. So this child, the AFP of this child after hepatectomy itself had come down to the normal value and post chemotherapy, and now he is remaining well. So I was about to ask sir about the AFP values and the trend of decline. So sir has already highlighted. Next slide, Ajita. So the 1 log reduction and the less than 100 and more than 12 lakhs being the high risk factors has been discussed. We'll go to the next slide. So this is a next patient who was diagnosed with hepatoblastoma initially in May 2023, had pretext 4 disease with portal vein involvement. There was a portal vein thrombus that was seen. And there were 2 indeterminate lung nodules, 2 with one size 3 mm, one 3.5 mm on bilateral lower lobe. AFP was about 10 lakhs. The child was treated with Cyopel 4 based neoadjuvant chemotherapy. And post chemotherapy, he did show reduction in the size of the mass, and the AFP was 35 nanogram per ml, and the lung lesions were not visualized. Next slide. So these were the post neoadjuvant chemotherapy images. However, still had portal vein tumor thrombus. Next slide. So this child was treated elsewhere. And in August 2023, after the imaging, he underwent a resection of the tumor and completed the further chemotherapy based on Cyopel 4 in November, and the AFP was 59 at the end. However, the AFP has always been between 100 to 150, and 9 months later, this child had a relapse, which was imaged. The next slide. So this is the imaging at relapse. Next slide, Ajita. So with this relapse, the child was treated with salvage chemotherapy, vincristine and irinotecan, 4 cycles. However, the AFP decline was not very dramatic this time, like sir has discussed. It was only from 19,000 to 11,000. And with this child, and there were no metastatic lesions elsewhere. So the child underwent a living donor liver transplant in Feb 2025 and also received 2 further cycles of vincristine irinotecan till May. However, within 2 months in July, he had a rise in AFP again to 1 lakh, and there were retroperitoneal nodes which were significant, suggesting a relapse again. Next slide. So I would like to ask Gomati ma'am, what are the indications of liver transplant upfront, and what do you comment upon this child's imaging and plan of treatment that you have discussed?
Well, I think unfortunately this child, the first resection was something which should not have been done, because what has happened is it's basically not an R0 resection. It's pretext 4, indication for transplant. Once the tumor responded to chemotherapy, the child should have had a transplant, which would have probably given the child the best outcome. Now, having had a resection which was probably macroscopically also positive, subsequent to that, the transplant was probably more of a desperate measure, knowing very well that the recurrence is going to be there, because this child has had all indications to suggest that this tumor is not going to have a good outcome even with transplant. So this child had an indication upfront. Subsequently, it was, I think, more of a no other choice kind of a thing that was offered. Now, in terms of upfront versus rescue, I mean, when we talk about rescue transplant, we could look at it in two ways. Salvage transplant versus rescue. This probably was a rescue and not as a good candidate for any kind of a transplant option. But if you talk about salvage in some patients where resection could be performed and then later on when they have a recurrence, upfront resectable tumor, R0 resection, and then come for a transplant later as a salvage transplant when they have a recurrence. Early days, it was thought that salvage transplant did not have good outcomes, but now there are quite a few reports, especially from high volume centers who do both resection and transplant. The papers from those centers understand what they have to do to get a R0 in the first time, and then if there is a recurrence later of a transplant, both have shown good outcomes. So I would say simple understanding, if a patient fits criteria, pretext, the ones that Dr. Girish had explained earlier, pretext 3, central vascular invasion, and pretext 4, these are patients who should go for transplant. Extreme resections have to be done only as an exception, not as a standard teaching practice.
Thank you, ma'am. So, as you mentioned, the prognosis of with rescue transplants are not that great. This is ICMR consensus document, which has clearly stated the rescue transplants offer a survival of only 25% when we can achieve more than 90% with the upfront transplant when it is indicated. So, I would like to ask about the post-liver transplant chemotherapy options, challenges, and practical points that we should know. Scott, sir, could you take it up?
So basically, when I joined Prof. Rella's team in 2015, it was a new entity, that hepatoblastoma post-transplant chemotherapy. So I had a discussion with Dr. Rajkumar Venkatramani. He was in that liver treatment group in Texas. So he said they would give 2 cycles. That time, the papers were very clear, although it's very small. It was 100 versus some statistically significant between the two groups who received post-transplant chemotherapy versus no chemotherapy. So that was very clear. We started with 2 cycles. The reason is there was disseminated like microstatic spread, microscopic spread, vascular invasion to prevent relapses. But the concern is post-transplant with immunosuppression, whether this chemotherapy will be tolerated or not. But anyhow, with benefit versus risk, we decided, and we have treated almost like 14, 15 patients. Nobody had any complication. Two patients relapsed. But when I did research now, literature review, it's very controversial now, and there is no clear guidelines. Some centers give and some centers don't give. But we are still adapting the policy of giving 2 cycles. What is to be given is uh, depends upon what treatment the child received initially, and if the child has not responded to the initial chemotherapy with a poor decline in AFP and the AFP was high, people used to change that from cisplatin based to irinotecan. Finally, what we decided after all the discussion is to give carboetapocite 2 cycles if the child has responded to Play-Doh type of chemo. If not, we are giving post-transplant irinotecan.
So if I can just add on this, actually we are just going ahead and giving it post-transplant. We've done for 25 transplants probably now for hepatoblastomas, and even post-transplant we are doing it 6th, 5th, 6th, 7th cycle of the Soapel high-risk arm. and we are going in and finishing. But our liver tumors surgeon is titrates the immunosuppression when we do the chemotherapy and when the neutropenia comes in. So they tend to decrease it for that 1 week, 7-8 days, and do it. So it's a real-time involvement of the liver transplant team who keep on adjusting the dose of the immunosuppression because now there is febrile neutropenia, etc. But we've had no major complications of delivering cisplatin, carboplatin, doxorubicin as well. So we've done all 3 drugs post transplant, and somehow it seemed to, though we were anxious about it, it seems to work reasonably okay. I agree with Julia that the anxiety is far more. I mean, we also had a lot of anxiety, but I feel that it is not. It's probably uncalled for. So
Thank you, sir. So the paper that was shown was from, it was a meta-analysis which had shown that, post-transplant chemotherapy is indicated in all, and only 2 had significant toxicities, and those 2 were had received ICE because they have not responded to the previous chemotherapy. And the point that you highlighted, AFP of more than 13,000 in a multivariate analysis before liver transplant had a very poor prognosis. It's independent prognostic marker that was highlighted in the paper. Next slide, Ajita. So, post liver transplant HPE, anything particularly we should be looking for? Dr. Divakar, could you take up? Anything specific?
So like how we discussed before, that if there is a change in basically the histology or any mixed histology that was seen on the initial biopsy, apart from the regular protocols that we need to assess.
Thank you. So, yes, so the gross and microscopic evaluation and the detailed vascular invasion, all that is very important for us to make a plan. Anyway, the chemotherapy is usually mandatory. Dr. Satish, if you could take up on the role of TACE and radiofrequency ablation in liver tumors.
Yeah. RFA is basically, the evidence is only for less than 3 centimeters. If it's more than 3 centimeters, you don't get good margins. So, I mean, with reference to hepatoblastomas, obviously these are big tumors. Like the first case that you showed where there is a 1 centimeter small nodule in the left lobe, where the bulk of the tumor is on the right in one segment, I think the first case that you showed, where there is a doubt whether this could be hepatoblastoma or not. Sometimes we'll do it intra-op. When they're doing, we'll do an intra-op ultrasound and do an RFA in the same sitting so that we don't have to do 2 anesthesias. As far as TACE or tear, which we have not mentioned about, is it's more loco-regional control. So as Dr. Girish was saying, this is a surgical tumor. So this one needs surgery. So all we are trying to do is try to enable this patients to go on and have surgery. So if the tumor is very big or the FLR is not large enough, or the patient at that point in time is not willing, which is more in our country, right? They're not willing for a transplant. They don't have money or things like that. Then we can offer all these things. But upfront surgery would be the best option. And these are all just buying time for the patient. And again, the need for biopsy, TACE-wise, if I'm going to do TACE, it's important to know whether we are dealing with a HCC or a hepatoblastoma, because the chemotherapy regimen that is used is going to be different. If you're going to do a HCC, we would mix the lipiodol with doxorubicin. Whereas if it is going to be hepatoblastoma, that will be a discussion that we have with the oncologist. Irinotecan is not a bad option. We have beads which you can put irinotecan in, and they absorb the irinotecan, and we use that for taste. It's called Debiri. So that is something which we will discuss.
Thank you. So we have to finish in the next 10 minutes. So next case, I'll quickly run through this case, who was a 13-year-old boy currently, initially diagnosed in 2015 with a pretext to hepatoblastoma, AFP elevated, treated with 6 cycles of Plado and resection. HPE was fetal epithelial type and remained normal for further 1 year, and then they didn't follow up later. He had come after 10 years now in October 2025 with right hypochondria, pain, and fatigability. This time the AFP is only 5.21. And the tumor, the lesion is shown, the CT images are shown. The next slide. So we went ahead with a biopsy. The morphology was more of malignant small round cell tumor. Next slide, Ajita. Next slide. Next slide. So we ran a lot of IHCs because of the histology, and finally there was patchy expression of flipican-3, beta-catenin membranous expression, FLI1 was nuclear positivity was present, and with INI was preserved, so which was most important in this case. So based on all these markers and final evaluation, it was finally labeled as an INI preserved small cell undifferentiated hepatoblastoma. We did molecular studies, which I'll share later. So I would like to ask our experts regarding the experience with a late relapse like this 10 years later, and what are the common sites of relapse that we see. Dr. Divakar, about the comments on this histology, and would you do anything else on this situation and the management strategies? Dr. Scott and Dr. Girish.
Yeah, it's very sad for an pediatric oncologist to have 10 years later the same child coming with a relapse. The first thing came to my mind was a second malignancy. But because the lesion was inside the liver again, usually we have to think of the primary tumor recurrence. But this time he was very jaundiced. That is not a very usual feature of hepatoblastoma, and the AFP is very normal. And the pathology showing small round cell undifferentiated, and he progressed within like 10 days. He had severe pain, so I thought it is definitely going to be rhabdoid, so we sent an NGS also. But finally, after every comprehensive IHC, and we have one of the best pathologists and liver expert he is, finally we decided to treat like a recurrence of hepatoblastoma with metastasis. We gave a very grave prognosis, and we had an upfront liver transplant documentation also. And we had a lot of confusion of choice of chemotherapy, because it is not a very clear-cut hepatoblastoma, whether to go with ICE or go with the irinotecan-based. And we gave actually alternating. Then you can, comments from pathologists.
So just before I comment on the actual histology, someone has also asked in the group that is SMARC-B1 or INI1 alone is sufficient to rule out MID in small cell undifferentiated histology. I would just, and Dr. Girish has also responded to that, I will just go one step further and say that if INI1 or even BRG1, which is basically a sister protein of the same lineage, if either of these two is lost, and obviously INI1 is much more common, almost 90% of the cases show loss, and BRG1 is very rare, it should not be called as a small cell undifferentiated hepatoblastoma at all. In the current literature, this is considered completely like how you guys were suspecting that it could have been a second primary also. If that would have happened, then a second primary of rhabdoid tumor should have been labeled, but they rightly called it a INI1 preserved small cell undifferentiated hepatoblastoma, and it probably represents either de-differentiation or a clonal evolution of the hepatoblastoma clone rather than a new tumor. And obviously seen in the loss of AFP production also, because there is no basic hepatocytic differentiation for AFP to be produced.
Thank you, sir. Next slide, Ajita. Giri sir, do you want to comment on management of the relapsed situations except vincristine irinotecan? Any other options you would consider?
So I'm not sure at all, because 10 years later I would have never thought this would be a hepatoblastoma. And all the overwhelming evidence is when relapse occurs, AFP does go up if AFP was elevated in the beginning. So to have a hepatoblastoma which is not having AFP secretion when it was 10.5 lakhs in the beginning has to obviously undergo some change, let's say differentiation or something like that, which has occurred to cause it not produce any AFP. So I'm not sure how you would have done this. So treated as high-risk disease, definitely, but you're given first-time Plado 6 cycles. So there's no question of giving. I don't think we should give doxorubicin. So vincristine irinotecan, carboplatin etoposide.
Then you want to continue the
Got it, sir.
response?
Yes, sir. So We did a PET here because of the histology, and the right one is the diagnostic one, and the left one is the current one. I mean, surprising to our expectations, we found that the child had dramatically responded to the chemotherapy. Next slide, Ajita. And he's being continued on chemotherapy and suggested liver transplantation.
But I want to ask Girish. Girish, I mean, have you seen any hepatoblastoma? All the Mets, I mean, with the 2 cycles to completely respond and the liver mass also to shrink. That I was very much surprised to see that response.
No, that is definitely there. That hepatoblastomas can have a dramatic response. The liver nodule and the pulmonary mets can completely disappear, and the mass can dramatically shrink. So that bit is completely okay. It is
Okay.
just not seen it in a non-AFP elevated hepatoblastoma.
Okay.
That kind of response without AFP being elevated is unusual. So, I mean, I would have even thought we should rule out sequence the GNC tumor and see what if there is some other diagnostic thing going on.
NGS was done for this child.
Yes, sir. So, next slide, Ajita. So I'll get to the NGS of this child. So this is for the thing, and there was MIC AMNIC amplification, and no other targetable mutation was present. So we actually did not get much help from the NGS with this child. Any comments on this?
So I think the AMNIC amplification just suggests that's an aggressive tumor. I don't think it's telling us more than that in this situation.
Okay, sir. So So next slide, Rachita. Fine. So I think with this, we've discussed few patients and a lot of concepts. I would like to just summarize by saying that pathological evaluation need to be more streamlined, and central reviews discussions would certainly help to gain more insights on disease biology. Timing of appropriate surgical or transplant referral is very crucial. Like Dr. Girish has been insisting that it's a surgical tumor, we need to have the surgeons on board from the time of diagnosis. Relapsed refractory hepatoblastoma needs more collaborative trials and newer insights into medical options, which we have to go a long way. Role of NGS and targeted therapy is evolving. Survivors of liver tumors are increasing, so we need schematic follow-up plans for all these patients. And collaborative studies are the needs of the hour. Next slide. So with this background, we would like to invite all of you for our Pediatric National Liver Tumor Conference, which is planned in Chennai on 28th and 29th of March. We do plan to have an INFOG liver subcommittee meeting as well to take the research in this area forward. Dr. Amandeep has kindly agreed to come over and moderate the session. And we invite you all. And thank you so much for my panelists for the extensive discussion. I hand over the session back to Ajita.
Dani, just this one question from Dr. Nirali Sangvi. I think Dr. Gomati may be able to answer that. An undifferentiated embryonal sarcoma of liver, but involving all segments except segment 2 in a 9-year-old. So it is like a pretext for only. So that be indication for transplant. You wanted to know how would you?
Yeah, I mean, if all segment 2 alone, essentially, you're not going to have enough remnant, and technically also leaving behind segment 2 is not easy. So transplant would be the option. What you would like to do with him before that is up to you all totally.
So
how you would like to prep him for the surgery.
Yeah. So the chemotherapy works well, and even sarcoma like family tree chemotherapy works pretty well in this. So 8 cycles of chemotherapy would do 4 pre-surgery and 4 post. So if there's a dramatic response and this maybe pulls back a bit, then I don't know if surgery is feasible, if it's a single mass and not multifocal disease. But many times it becomes kind of cystic, kind of thick tumor, not really disappear in size.
Okay.
So, thank you, ma'am. Thank you, Girish sir, for answering all those questions in detail in the chat box. And Any final thoughts from Dr. Girish and Dr. Scott?
No, I would just say that this is truly an upfront discussion. So every case you must discuss on day one itself with the surgeon, radiologist, plus and pathologist as required, and you must assess every 2 cycles whether everything is falling on track, we are able to do surgery or no. We should not pick up at the 6th cycle that the liver remnant is so small, we should now do a portal vein or a TACE to actually increase the residual liver. If we want to do some decrease the tumor size by TACE, all that has to be planned. So I think it's, though the numbers are small, but it's a continuous discussion. It is not like discussion now, discussion after 4 cycles, and discussion end of treatment. It is every cycle discussion. So for the trainees, I would say you must understand AFP kinetics very well. That is so crucial for you to decide whether the child is going to do well or no. And please time the surgery on time.
Thank you, sir. Dr. Scott?
Yeah, I just want to insist that the pathologist is one of the most important in the liver tumor. So unless the pathology report is very clear, and as Girish said, the upfront documentation by the surgeon. Because if the parents are told of an indication which was present in the initial scan, like a portal vein involvement or a centrally localized, and then the transplant is suddenly told to them after 4 cycles, they will be very upset. So upfront documentation of the transplant surgeon is very important.
And it also helps to prepare if they need a transplant.
Exactly.
The donor preparation has to start. So
thank you. Thank you for all the experts for your valuable time and your insights. Final words by Dr. Shweta so that we can wrap up the session.
Thank you, Ajita, and thank you to all the panelists, Dr. Dharani, Dr. Julius, and Dr. Girish for a wonderful session. We learned a lot today, and I think it has been very well highlighted today that multidisciplinary team is very much required to manage these tumors. Even if they are simple or they are complex, we need to discuss with each other to give the best management to the patients. And with this, we would like to close the session. Thank you so much.
Thank you. Thank you all.
Thank you, ma'am.
Thank you.
I'll end the meeting now.